which he's told me he's very excited about. I've told him to talk slowly, so it'll likely be an abbreviated session, but we'll have a lot of time for discussion, so we're excited about that. So I think most of you know Keishan. He's one of our rising stars here, third-year cardiology fellow, graduate of Northwestern Medical School and completed his residency at University of Chicago, got tired of the cold and made the wise decision to move down here for fellowship. His primary research interests are heart failure, pulmonary hypertension, and the intersection between the two. He is pursuing training in clinical pharmacology at UNC as part of the CRTP training program. He'll be chief cardiology fellow next year and will be completing an advanced heart failure fellowship the year after that, with primary mentorship from Adrian Hernandez and Scott Palmer. So please join me in welcoming Keisha.
Thanks. Thanks. So we'll have an abbreviated kind of talk, just like Emily said. So please make this interactive and get you out of here early, probably. But so I'll be honest. A year ago, I did not know a lot about the Jackson Heart Study. I've learned a lot since then. But when Rob and Emily called me to into a meeting to kind of talk about research plans and talk about doing the Jackson Heart Study, they said, it's going to be a lot of fun, and I said sure. And it has been fun and really interesting. So again, thanks for the opportunity to give this talk. And so today I will be talking about kind of two studies and try to connect the two. The first will be looking at the prognostic significance and the development of increased heart rate over time in the Jackson Heart Study. And then we'll kind of transition to how do we apply findings like these to the broader population and talk a little bit about population-based cohorts in general. So a little bit of background first about Jackson, Mississippi. So you may know that Jackson is the capital of Mississippi. It's also the largest city in the state. Andrew Jackson is the namesake. And Jackson, Mississippi, if you search for it online, there's actually some really pretty depictions and pictures of the city. And so this is the capital and the surrounding area, but probably not photographed as much as some of the other areas around the capital. And so I wanted to just highlight there's different faces to the city, and this will become a little bit more relevant towards the end of the talk. So just keep that in the back of your mind. So data collection for the Jackson Heart Study began in 2000. The mission of the study was to kind of understand and further characterize cardiovascular risk factors in a Black community cohort. There were actually 3 exams throughout the study. So exam 1 was from 2000 to 2004. Exam 2 was 2005 to 2008. And then the third exam was 2009 to 2013. And so patients actually had a good amount of information collected from each of these exams. There was demographics, baseline medications, comorbid conditions, labs. They actually had an echo done at their first exam, and then they had EKGs done at each of these exams as well. And the EKGs, you also had a resting heart rate obtained from it, so an additional piece of information. And EKGs that were kind of outside of these pre-established parameters were overread by physicians, so pretty good data quality too. And so there were 5,301 participants in this prospective community cohort that started out with exam 1. And this represents the largest kind of collection of Black participants in a single site to be studied. So pretty good undertaking, and we'll talk a little bit more about that in the middle of the talk. So I'm just shifting gears for a second to heart rate. Heart rate as a prognostic factor and as a therapeutic target, as some of you in the audience know, has gained increasing attention over the past 10 years. And so shown here is the Framingham data. So patients were divided, or participants in the Framingham cohort were divided by their heart rate, and the y-axis is the cumulative incidence for heart failure. So higher heart rate leads to a higher risk for heart failure over time. And there's actually really similar relationships for all-cause mortality, although I didn't show that here. And looking at prior heart failure trials, so the x-axis here shows a change in your heart rate from the beginning to the end of a heart failure trial. And this is regardless of the drug that you're on, so it's just looking at the heart rate effect. The y-axis is the mortality benefit or detriment with that heart rate change. And on one end of the spectrum, you have the carvedilol studies like MOCA and US carvedilol that lowered your heart rate. And then the other extreme, you have PROMISE. It's probably a different PROMISE than you guys are aware of, but it was a study of oral milrinone. And then Profile, which is another vasodilator that's not on the market right now. Both of them ended up in increasing your heart rate and associated with a mortality increase. Now, the one common theme for both of these studies was that the Framingham obviously looked at primarily white participants, and a lot of our heart failure trials, unfortunately, have not been really representative of the country's population, so mostly white. But regardless, with all that momentum over the last several years, it led to the study of heart rate as a therapeutic target in heart failure. And really exciting. So a new class of drugs, funny current blockers, and avabradine was the name of the drug. The name of the trial was SHIFT. And SHIFT looked at patients with New York Heart Association class 2 and 3, so about half in each one. They had reduced ejection fraction, and they all had a heart rate of 70 or higher. About 90% of them were on a beta blocker, and the primary endpoint of the trial was a composite of cardiovascular mortality and heart failure hospitalizations. And it led to a positive result, and driven primarily by heart failure deaths and heart failure hospitalizations. The placebo group in SHIFT had a baseline heart rate of about 80, and it went down to 75 just with the placebo alone. The study drug actually went down to, I think, 67 or so. So a good decrease in the heart rate. I didn't show the results of the primary trial here, but this is actually a secondary analysis that looked at just your baseline heart rate and your outcome over time. And you can see that there's a pretty good separation just by your heart rate alone at baseline. So great, these are really interesting results. They're exciting for all heart failure patients, right? Well, not actually, because while the trial was really kind of big, at 6,400 patients and 37 countries, it was primarily done in Europe. There were a few patients from China, India, and Australia, but no US sites. And why is that important? Well, it's not really representative of the American population. So 15% of the American population is black. It's about 2 to 4% here are classified as other, so some portion of those are probably black. And again, this is important because blacks have different baseline comorbidities. They have more left ventricular hypertrophy, more hypertension. They just have a higher kind of burden of cardiovascular diseases in general. So it's not, so there's this unmet need of information. So sometimes in research, I feel we have, as fellows, we have access to really great data, and we feel like we have this big hammer and we can really get anything with the nail, or everything looks like a nail. So this is a picture of my daughter who got a hold of my stethoscope a few weeks ago, and after giving me a checkup, she proceeded to listen to everything around her, and for the next probably like hour, including her future sister on the right side there. But so anyway, the point is that I felt like this was actually a case where we had a hammer and a nail, unlike this, or at least we felt that way. So going on to the objectives of our study, the primary objective was to look at the prognostic utility of heart rate in a community-based black cohort in Jackson, Mississippi. We'd look at all-cause mortality and heart failure hospitalizations. And then secondary objective was to look at predictors of developing increased heart rate over time. And that was a kind of a novel investigation, hadn't been done before. This is just a quick concert diagram of our patients. So we had the 5,301 patients in the Jackson Heart Study to start out with. 40 patients were excluded because their heart rate was just indeterminable. They were being paced, or they had an irregular heart rate from atrial fibrillation. And just of note, the heart failure hospitalizations, which was one of our outcomes of interest, surveillance for that actually did not start till later on in the study. So that was another time point of interest. And then finally, In terms of looking at the predictors of increased heart rate over time, we had exam 1 and then we had exam 3. So we were able to measure the difference among patients who actually completed both exams. So we split up our patients into 5 different quintiles by heart rate. And so the highest quintile should actually read greater than 72 beats per minute, not 73, but is shown here in addition to the other quintiles. And they were more likely to be female, have more heart failure, they had more hypertension, diabetes. They're more likely to report no physical activity per week, which I thought was interesting. It's a pretty high number regardless. They had higher BMIs. Again, pretty high BMI throughout. Just more reflective of our country, probably. And the other interesting thing I thought was that the patients in the highest quintile actually were the least likely to be on beta blockers. And interestingly, these patients had more heart failure, hypertension, diabetes, and higher heart rates, so potentially more reasons to be on beta blockers as well. Ejection fraction and BMI actually didn't vary a whole lot between, and caffeine consumption did not vary a whole lot between the quintiles. So looking at the results, so the y-axis here is your cumulative incidence of all-cause mortality, and then the x-axis is your years of follow-up. So we had 9 years of follow-up for this outcome. And if you can compare to the green line, which is the lowest quintile, less than 55 or 56 beats per minute, the middle 3 quintiles are slightly higher in their risk for all-cause mortality, but then this, the top quintile, the 73 to 118, is obviously much higher, and it diverges pretty early on too. And we also looked at heart rate not only as quintiles, but also as a continuous variable. So after adjusting for the variables that you see there, we did a spline analysis, and you can see that there was this linear association with mortality and heart rate as a continuous variable. So just kind of confirming our results.
Can you tell if all these people were in sinus rhythm?
So they were not necessarily in sinus rhythm because the only people we excluded were AFib and pacer. So I don't know if they were in flutter or block or things like that. It's a good point, though. And then looking at heart failure hospitalizations, I didn't blow up the graphs here, but it was a pretty similar trend in the relationships. So higher heart rate with higher risk for heart failure hospitalizations, especially in that top quintile when you get past that 73 beats per minute cut point. So not to show you all the numbers here, but really just to show after we adjusted for those risk factors, if you look at the hazard ratio for the 73 to 118 quintiles again, you can see that that hazard ratio was maintained. So 2.1 to 2.4 for mortality, and then 2 to 1.8. So pretty strong evidence, I thought, for an association. And then in terms of the secondary objective, what factors are actually leading people to potentially develop increased heart rate over time? And through a whole slew of variables, actually, only 3 came up. And we defined increased heart rate as an increase in 5 beats or higher per minute. So having diabetes, being a current smoker at the time of your exam, and having a left bundle branch block, which is just a conduction abnormality, were all predictive of developing an increased heart rate over time. Interestingly, I thought, so being on a beta blocker was associated with having a higher heart rate unadjusted, but when you adjusted, it didn't have any effect, including, you may think that the beta blocker would prevent you from developing the increased heart rate, but there was really no statistical association. So I thought that was interesting. What else? We also did a sensitivity analysis to see, so the previous results were with a 5 beats per minute threshold. We increased that threshold to 10 beats per minute. So what factors still held true with a 10 beat per minute increase in just diabetes and being a current smoker at your baseline exam? People who actually had quit smoking prior to their exam did not have that statistical association. It was just people who were currently smoking. So some good advice still holds true. don't smoke.
Was the beta blocker just baseline, or were you able to tell if somebody started or stopped it?
It was just baseline. We had that data, actually. We didn't look to see what changes in beta blocker use did. It was just the baseline. Yeah.
When you're talking about diabetes, you're talking about controlled diabetes, uncontrolled diabetes,
Yeah.
H1AC ratio,
That would be great.
correlation.
I don't have that granularity,
Yeah, okay.
unfortunately. Yeah.
I figured you'd have it if you did, but.
Yeah, no, that's be really interesting.
The previous analyses you showed about, you don't mind if we ask questions?
No,
Joe?
The page already open.
Because we
Yeah, absolutely. No.
I'm just following Granger's lead. But the previous analyses you showed us are all the relationship between baseline heart rate and outcome.
Yeah.
Did you look at the relationship between change in heart rate and outcome?
We did not, no. I don't know. The only time I can remember seeing that kind of data being presented is that kind of analyses of all those heart failure trials where we looked at change in heart rate. I haven't seen that kind of data presented before. That's an interesting question.
Because it's intuitive to think that, baseline heart rate is predictive of outcome, that having your heart rate go up during the observation period should be predictive of outcome.
Yeah.
But it might be that the outcomes are driving the higher heart rates at visit 3.
Absolutely. Yeah, no, and that kind of leads me to my next point. We don't know this information is helpful. It does get us a step forward in terms of identifying heart rate as a prognostic factor, but it doesn't get us to the point where shift is, where we know that treating it can help. So that's an important distinction to make, and it kind of shows here. So the take home from this study, we did establish this linkage between increased heart rate and mortality and heart failure hospitalizations in a Black community cohort, and diabetes, smoking, and the left bundle branch block predicted people who went on to develop an increased heart rate. But just like Dr. Alexander was saying, it's really unknown whether an intervention would be beneficial in this population at this point. And I wanted to take this time to just put in the plug for Prime-HF here. So like I said earlier, this study drug has not been studied here in the States. And so we're actually, under Rob Mentz and Adam DeVore, we'll be studying the rollout of ivabradine in patients who were just hospitalized for acute heart failure and actually give it to them right before discharge. So we want to see how we can kind of incorporate this new class of drugs in a heart failure regimen in patients really at need for some improvement in their therapy. So it'll be an interesting study. Just really briefly, this just shows this kind of the scheme for how the study will go about, but they'll be started on the drug or have their usual care prior to discharge, and then they'll go to follow-up. And we'll get some interesting data in heart failure trends, quality of life, and some other harder outcomes as well. So stay tuned for that. And hopefully we'll have a higher Black kind of enrollment too, so we'll have some more data from that. For Prime, yeah.
Okay.
Yeah. So I have my own thoughts about this question. Is this representative for a broader Black population? And this is talking about the results we found from the Jackson Heart Study, but I wanted to know what the audience kind of thought about that too. Any comments or thoughts? How would you take what I showed you to apply to a larger population, or would you not? That's another option too.
Part of it, I think, has to do with control of other risk factors, right? I mean, blood pressure, diabetes, other things, that, it's known that other risk factors are more prevalent in the Black population. So you'd have to make sure that you have that baseline well established and then understand on top of that, where's baseline heart rate and how we mentioned you adjusted for beta blocker use, but it's clearly that people with faster baseline heart rate were less likely to be on beta blocker, and is that a cause and effect or just an association? And trying to understand that better would be really important, I think.
Yeah.
Like why they weren't on a beta blocker.
Exactly. And so, and this is going to kind of the theme for the last half of the talk is understanding, knowing the population you're studying before you come up with the questions, because it really kind of changes what kind of answers you get. And that might be really obvious, but kind of when you're in the midst of it and looking for a nail to hammer, it can get a little bit clouded. So.
Did you have socioeconomic? You must have socioeconomic
Yeah.
Was that not a factor? Or was
Not in the heart rate analysis. We didn't look at that as far as I can remember, but I'll get to that with this analysis here. Melissa, Melissa's here. I don't think we looked at social.
Like alcohol, drug abuse,
So,
that kind of
yeah.
thing too might be
So in terms of
associated with-
socioeconomic status, we were limited in terms of what the Jackson Heart provided, but we did have Medicaid eligibility, and I'll show you how we used it in this next study. It's a good question. So actually, the inspiration for studying this came from some of our DCRI faculty from a couple years ago. They looked at the cardiovascular health study and its kind of representativeness for a broader population. So the cardiovascular health study, for those who don't know, it studies 65 and older participants, so the elderly, and looking first, or not so elderly, but older. How about that? And we're looking for cardiovascular risk factors, so similar to kind of the mission of the Jackson Heart Study. And actually, and what they did to study this was, in terms of looking at the applicability of their findings for a broader population, was to look at Medicare cohorts. And so the CHS was based in North Carolina, California, Pennsylvania, and Maryland. And they assembled this regional cohort using people from the census regions from each of those 4 sites, and then got a 5% analytic sample from that cohort. And they did the same thing for a national Medicare cohort. And their comorbidities were actually really similar, so that was good news. But interestingly, there was, as you can see here, there was a pretty big difference in their mortality, in their outcomes. So keeping that kind of in the back of your mind, we use some of their methods and ideas to understand what the Jackson Heart Study kind of meant for the broader Black population. And so we, because of our ability to look at outcomes with Medicare and kind of the unique things that we have here at the DCRI, we created a Medicare Jackson Heart cohort of about 1,100 patients. And these patients were on Medicare by virtue of being 65 or older. And we compared them to 2 cohorts, similar to what the prior study I showed you did. So we looked at the South Census region, which includes Jackson, Mississippi. So that's 17 states. They're all the ones in orange. And we used about a 5% sample. We used a 5% sample of that. So that's 57,000 patients. And then we had a similar national Medicare cohort, about 95,000 patients. So here, I just was curious to see, does anyone know what that map on the bottom represents? That's a good guess. So it's actually the GOP primary. As I was creating this, I was thinking it might be interesting to do a similar study on that. Anyway, so we had 3 cohorts. We had the Jackson Heart Study Medicare cohort, a regional 5%, and a national 5%. And we had some really interesting results, actually. So unlike the CHS, the comorbidities in the Jackson Heart cohort were actually very different from the regional and the national Medicare cohorts. And these are all Black participants, by the way. So I don't know if I mentioned that. So the regional and the national 5% samples were all Black as well. So overall, the Jackson Heart participants were younger. There were more females. There were strikingly fewer patients who had this dual Medicaid, Medicare eligibility. So getting to what Dr. Granger was asking about potentially controlling for socioeconomic status, that has been used as a surrogate for socioeconomic status, and so that was interesting. And then just looking at their overall burden of different comorbidities, the Jackson Heart population has, they have less cerebrovascular disease, COPD, heart failure, dementia, diabetes, and ischemic heart disease, so kind of across the board. Whereas the regional and the national seem to line up much more nicely. Any thoughts or questions about that?
Well, have you explained that?
So we'll get to that. But it's a very good, I think that's the $1 million question.
And Keyshawn,
Yes.
I would just add that the regional and the national comorbidities are age and sex adjusted.
Yes. Thank you for mentioning that, Melissa.
They would look even worse.
Yeah. Yeah. So I was really impressed when I saw this graph for the first time. I think Melissa had emailed it to me, and I didn't know what to do with it. I had to pick up the phone and call her just to make sure that I was interpreting this right. So the regional and national cohorts are in blue and red, and they're basically on top of each other. This is the cumulative incidence for all-cause mortality, starting from 2003 with a 10-year follow-up, and their JHS cohort is in green. So really striking how different their survival is over 10 years. And there's a similar relationship with all-cause hospitalizations. And the source of data for all of this, I should mention, is all the same. Even though we had access to some data from Jackson Heart data, we got it from Medicare just to make sure everything was kind of standardized. So
would you defund Jackson Heart?
no. No.
You get too successful, you don't need funding anymore?
Yeah, you could argue that it made a difference in these. No, so I think,
Just being in the study made him.
yeah.
Yeah, well, they're younger.
This is the risk of being in clinical
Yeah,
trials.
it's too bad Emily's not on the hot seat
In
to
clinical studies.
defend the epidemiologist in the community.
So we'll get to some of these. So I mean, the rest of this talk is basically trying to figure out why we saw such really disparate results, unexpected actually. And we went back to the drawing board. We looked at how are these populations different besides these comorbid conditions, and we went back to the socioeconomic status. Maybe there is something to that, especially since we saw so many fewer patients having this dual Medicaid eligibility. And there's been numerous studies, some of which are from here, showing that socioeconomic status is really a strong predictor of outcomes across the board for different diseases. And so shown here are the adjusted hazard ratios for mortality and all-cause hospitalization hazard ratios in reference to the Jackson Heart cohort. What we did to try to control for your socioeconomic status in a more kind of in a more structured way was just to basically just examine those patients who had the dual Medicaid eligibility. So it's a subgroup analysis. And that's in yellow. And you can see for mortality, at least, for both actually, the hazard ratios they were attenuated, right? The association between mortality and being in a regional or national cohort was attenuated, even though they're still significant. So a couple of things you can get from this. One is that having the dual Medicaid eligibility is a surrogate, maybe an incomplete surrogate for socioeconomic status, and we don't have the whole picture, but it's some of it. And then the other interesting thing is that I haven't told you yet is that over the course of the follow-up, of the 10-year follow-up, a good proportion, almost 60% of our Jackson Heart participants switched over to managed care, Medicare, and so we just lost the ability to track their outcomes. Those participants tended to have a slightly higher incidence of having this dual Medicaid eligibility. It was like 28% versus the 20% in the rest of the participants. So that's something else that I can't really account for otherwise. But even despite that, there are still these differences, even if we, even accounting for that percentage of patients that went over to managed care. So to try to get a better sense of socioeconomic status playing a role in this and looking at other factors, we went even further back to the drawing board and looked at one of the original papers that came out describing the methodology of recruiting participants in the Jackson Heart study. And for some of you may know this, but the Jackson Heart study was initially composed, or their initial kind of participant population was from the ERIC study, the atherosclerosis risk in communities cohort. And so about 22% of the Jackson Heart study was derived from ERIC, and then they had another 30% of family members. But recruitment was really tough for the Jackson Heart site, and especially so compared to the other ERIC sites, the Jackson Heart site, Jackson, Mississippi, they had, I think, 20% fewer participants actually stayed on in the study after their initial home interview. So recruitment was challenging not only for the ERIC study, but also for this. And so then they implemented some other ways to kind of gather up more Jackson, Mississippi residents for their study. So they did some random sampling, and then they actually sought out volunteers as well. And as you can see, that accounts for about a half of their cohort. And really fortunately, they actually published a lot of what they did with, or what those participants look like. So it's a little bit blurry, and I apologize for that, but you have 3 columns basically: the total Jackson Heart population, those that were recruited as like a second effort after the initial recruitment wasn't all that great, and then you actually have census data from 2000, which is when a lot of this recruitment was happening from Jackson, Mississippi. So I want you to compare the total cohort to the census and then the random volunteer cohort to the census as well. And you can focus on the education and income, and you can see that overall, so if you look at the proportion of participants who had a college education, for example, it's just 17% of the Jackson, Mississippi census, but a whopping 35% of the random volunteer cohort and 30% of the total JHS cohort. And then similarly, if you look at income, so if you look at people making $50,000 or more in a year, about 21 or 22% in the census data versus 42 or 33 in the Jackson Heart study itself. And and that acknowledging that there's some bias here, people who are making more than $100,000 are perhaps less likely to report their income, but I think the trends are pretty clear that this is a different population from Jackson, Mississippi, or what you would otherwise think of as Jackson, Mississippi, maybe. And I'm just kind of drawing everything to a conclusion here. So we maybe don't have a black and white answer for why we found what we did, but I think we have some pretty good potential reasons. So we did identify these important baseline and outcome differences between the Medicare Jackson Heart cohort and the regional national, and that may actually represent the Jackson Heart study and its ability to represent the regional and national Black population. The CHS study that I initially cited had kind of postulated healthy volunteer bias as a reason for why there is this outcomes difference between their cohort and then the general population. And I think that probably applies here too. And then the socioeconomic status, which we've gotten at a little bit, or I think as best as we can, probably has something to do with it too. And again, just thinking about the hammer and the nail, before we ask a question, I think it's really important to identify what we have to work with. That doesn't mean, so going to Adrian's question about should we defund the Jackson Heart study, I don't think so, because perhaps we can't use the absolute prevalence and some of maybe even the quintiles of the heart rate may be off from the general population, but the relative trajectory and kind of the pathophysiology that occurs after heart failure, once you have heart failure, there's no reason to expect that to be different. So maybe now the question is how, once you have this diagnosis or once you've been identified to be at risk for it, having a certain diagnosis, how do people do at that point? So it's a relative trajectory that may be the strength of this kind of study. And again, going back to the beginning, so just remember there are many faces. Even though this is thought to be a pretty singular kind of unified cohort study, there's different aspects to it that may look one way if you look at it one angle, but then a completely different way in another angle. And I have one or two more questions for the audience, but I just also wanted to thank, before I forget, the team that's really worked on this with me throughout the whole year. So Melissa, Emily, Rob, Leslie, Adrian, and Chantel has kind of kept me in line over the past year. So yeah, thanks everyone. And I have one or two questions, but if there's other questions or comments, I don't know how we're doing. So feel free to ask questions. Yeah.
Great job, Keishan. One thing that was kind of striking to me was when you showed that slide where you focused in on the dual eligible population and looked at all-cause hospitalization and mortality. It was interesting that there is a definite increase in mortality, but really no difference in all-cause hospitalization, which makes me wonder, is it a difference in access to healthcare in like an urban versus maybe a rural area? Like, were you able to look at trends in other urban centers in the South versus Jackson? Or was it, because it looks like, based on what you did, it was just all across the Southeast compared to Jackson?
That's a really good question. So, and it's a good point. We did not look at that particular point, but we did have, I didn't show you all the data from our study, but we did look at resource utilization and ED encounters, and controlling for socioeconomic status actually took away the significance of, so the regional national cohorts used their EDs more than the Jackson population, but after we adjusted for, we looked at the subgroup analysis of just dual Medicaid eligible patients, that relationship went away. There was no difference then. So I think that access to care is one part of it. And then actually I think Emily's been to Jackson, Mississippi before. I don't know if you want to speak to, right? Am I right? Or
I have been there.
I don't know if you looked at the hospital or.
I've not been at the hospital.
Okay.
But
It seems like everyone's in the Jackson Heart kind of their demographics in exam 1 are listed as having like an urban location, but I don't know if that's actually true.
it's loosely defined. It's like a slightly larger Carborough.
So, I mean, they actually have a kind of interesting community because they have a medical mall. So, like, one of the things that Jackson's tried to transform is like different industries have left or changed how to do that. And so, like, a lot of things right now that happen for healthcare happen in essentially a mall that's been converted to a medical.
So, question, just broad question for you. So I think the undertone here, and actually sort of tangentially related to Adrian's question, is that these types of traditional cohort studies are very expensive to do. To characterize a population to this level and follow them over time is a big lift. And so I'm wondering what you've learned about the types of questions that can best be answered in this type of population versus, say, a national network where there's a limited number of data elements available through common data model and it's encounter-based, and relative strengths of a study like this versus something.
I think that's probably the best kind of question to take away from this, I think, because as we have access to EMRs, as the Google baseline study is taking off, and there's been recommendations to kind of combine these cohorts into a consortium of like just pooled data. The question is then, should we even be doing these population-based cohort studies? So I think like for Framingham, for example, which started in the 1940s, it led to the identification of these really novel cardiovascular risk factors like hypertension, hyperlipidemia. You could argue that we don't need them anymore because we kind of know those risk factors, but I think, so kind of going to your question, Emily, I think we can use cohort studies like this to understand the changing diversity in the country, so that's one aspect of it. So, for example, Framingham only had white participants. This was able to focus on African Americans, and so you're able to look at a targeted ethnicity or another type of subpopulation. That's one, I think, part of it. And the second is this can still be hypothesis generating. You can use the data from this to kind of make new scientific discoveries. Maybe not answer the questions, but to help that along. I think I think in general, though, the argument for this is certainly not as strong as it used to be, based on having other sources of data now. Yeah, sorry.
One question and then kind of one minor comment. So, kind of extending that thought. So, it's been announced that there's going to be a significant investment for the Precision Medicine Initiative, and so, things like heart rate will be certainly of interest, but measured in a different way. Do you feel like there's lessons learned here for that initiative, and or you know, what's going to be the approach? And then the second thing, which I didn't catch before, is that we usually like to show data in quartiles, not quintiles, or sextiles, but not quintiles. Anyway, that's just something more, a minor comment that can be addressed later.
Well, yeah, I think the paper is in submitted already, but
For PMI, I mean, I guess.
yeah, no, for
NIH and tell Francis that he's
So-
got it all wrong and he's about to waste $300 million.
no, the lessons that I've personally learned from encountering this and then kind of thinking about the precision medicine initiative in the context of certain diseases is maybe it's better to, before we start collecting lots and lots of data, to at least start a list of questions that need to be addressed or that can be addressed with the available data. And it just sets, I think it sets yourself up to have a more streamlined process, and then you may not have to go back to like the 2005 paper, for example, and try to glean whatever you can about socioeconomic status if you had that built in already, to kind of think about how is this going to be different from the broader population I want it to apply to. Those are potential ways of, so I know it's always hard to do, but whatever foresight in terms of planning, and I'm sure this is happening already, but that's probably the biggest thing that I would say.
Keishan, what was the consent process for these various components of Jackson Heart?
The participants consented before they were enrolled, obviously in 2000. Are you asking if they had more consents in their different exams?
I'm just asking, like, the process of obtaining consent. Yeah, I mean, it gets to this whole issue. I mean, the broad issue here is this trade-off, right? And I think as you're describing it, and most of us would strongly agree, it's not one is better than the other. And for the time being, we're going to need to do both. We're going to need to have carefully constructed, detailed data and follow-up from cohort studies where there is selection, where they're not representative. And then we're going to have unrepresentative, or we're going to have representative populations where we have less high-quality data. We're going to have both. And they serve different purposes, but there's not like one that's better than the other. It just depends on the purpose that you're after.
I think you're right.
But one of the selection pieces is this consent, and I think we really underestimate this. To give, like you
have to be able
your
to be
baseline
informed.
characteristics, there were much fewer strokes and much less dementia. And of course, you kind of have to be able to be informed to give informed consent.
Right.
And that automatically identifies a different population based on the ability and maybe also the willingness based on those factors. So how consent is, some consent is obtained, like I think part of Jackson Heart was like opt-in or opt-out from a driver's license or something like that. I don't know if you know about this, but I think there were different approaches, but I think it's really important, like you said, to understand how do people get into a study to be able to understand what is the population.
I think that's a really great point that you're making it. I think the other thing kind of to think about is when people are consenting for this is the other kind of strength of these types of studies is this becomes kind of like a national resource, and you can use this database to ask a whole range of questions as opposed to potentially different types of data sets that are created for different purposes and may not be as accessible. So yeah, did you have something else to say, Dr.?
No, I was going to say, the other possibility, which I think nobody would advocate as likely being true, is that being in the Jackson Heart study improves your outcomes, right? That and it's hard to separate that from the selection, but that having regular follow-up with people who are asking about your health care actually makes you have better, or actually your health status actually does improve your outcomes, and we don't know that.
Yeah.
You can't. It's hard. You can't tease that out from the way the studies are done.
Absolutely.
Well, I think it's a really important point because as we look for more continuous monitoring, you wonder what that type of real-time feedback.
Does it actually influence the Hawthorne effect, that watching people changes their behavior?
Yeah.
And my last question is, how do you, what advice do you have, including for other fellows, about how do you access NHLBI cohort studies, get the analyses funded. You know, is this a good, should we be doing more of this?
I mean, yeah, to me, and I'm sure other fellows who've taken advantage of this opportunity and others, it's kind of like a kid in a candy store. We kind of get to, as fellows here, we get to bypass some of the other application processes that you need to go through to access this type of data, and you are able to really kind of pinpoint your question to what you're interested in. Whatever, yeah, the answer to your question is yes. Whatever opportunities there are to access these types of data sets would be great. I don't personally have experience with applying for funding for access to these kinds of prospective cohorts, but from what I've heard, it can be kind of complex.
Just to clarify, there's two different ways you can access these data.
Okay.
You can either go through the investigators directly, which you then need to get okays from them and get access to things, or you can go directly to BioLink and get it directly from NHLBI. Advantages, disadvantages of the two systems. One is very straightforward. BioLink is easy to get, but there is not a lot of user holding hands, and there's some data that are not in there that are in Jackson Hart, the investigator collection. So it's sort of like a private collection and the public variety, but either one can be accessed.
Is the BioLink data access free? Do you have any sense of how often it's used?
Yeah, so there's been publications put out by that. Lauer and others have done those. We have all those data here. We're linking all the cohort data together. We'll be one of the few places in the country that will have that.
Okay.
So that's potentially also available to people. So if you want to cross over Mesa and Eric and Framingham and create one massive database, that can be done.
All right. Well, thanks again, everybody.
Good job.